And noon is here. So welcome to the noon meeting. My name is Gilson. I'm the head of the Health Policy and Systems Division. It's lovely to see old friends, new friends, and a range, a diversity of people in the room. Thank you for coming. I am setting my timer for 30 minutes, so I'm trying to talk for that, to leave time for conversation. But you never know. But as you know, I have this thing that goes off after a certain period of time. I do it to some of you, so I'm going to do it to myself. So I'm going to talk to you today. This is the title, Everyday Resilience. The work that I'm going to be speaking about is drawn from this program called RESIST, which stands for the Resilient and Responsive Health Systems Consortium, which has been in existence for some time. Let me just compare. Oh, very good. So we've been working together since, I think, actually 2010, even though that says 2011 official beginning. There are groups in Africa, Asia, and the London School of Hygiene in the UK who are part of the consortium. We called ourselves Resilient and Responsive Health Systems before the word resilient had become widely discussed in health policy debates, and I'll come back to that point. The particular work that I'm going to be talking about this afternoon comes primarily, or is drawn on experience primarily in South Africa and in Kenya. And there are three groups who have conducted work that I'm drawing on. Ourselves here in UCT, and the work in UCT is a collaboration between the Health Economics Division and the Health Policy and Systems Division. Then colleagues at WITS in Johannesburg, and finally colleagues in the Kenya Institute of Medical Research in Kenya, doing work particularly in Kilifi, which is very close to Mombasa and is a beautiful place. I encourage you to go there. So, oops, let me go backwards, not forwards, that's very good. So, I just want to start briefly with the starting points of this large multi-country, multi-organisation consortium. Funded by the UK government, DFID, the Department for International Development. Our starting point, our overall programme of work was founded on this hypothesis. I put it in inverted commas because hypothesis means different things to different people. It's a broad proposition that if you can strengthen health financing of health systems, issues to do with health corporate training and management, and issues to do with the governance of systems, that strengthening will enhance or increase the resilience and responsiveness of health systems. So we started with that notion when we began our work. And we had an understanding of resilience that was drawn firstly from Meadows, who's a writer on complex adaptive systems, that resilience is something to do with a system's ability to survive and persist, ability to learn, diversify, complexify, important to note that, not simplify, complexify, and endure. A second definition that came from popular theorists, a book I picked up at an airport once, Zully and Healy, all writing about resilience, ability to adapt to changing circumstances. And then we identified some features of resilient human systems that the theory said mattered, and in a sense what we've tried to do is explore whether in the work we've done these types of features have been seen to be important. So we started with this set of ideas. It'd be great if I could go forward, not backward. And as I said, we started with a name using the word resilience before it had become incredibly fashionable in the health policy and systems world. And in the wider world, this is just very basic Google hits. In the 2000 to 2010 period for the phrase resilience and health system, there was about half the hits on Google Scholar than there has been in the 2011 to 2017 period. So there's been a growth in interest in the area of resilience and health systems in the health systems world. But it's dwarfed by the amount of literature that there is on resilience outside the health field. Here we are, dwarfs, and here is the broader world that encompasses a huge range of different bodies of literature, where we're talking about hundreds of thousands of pieces of work. So we were before our time in our name, yet in the health field, there's been a growth of interest in resilience. But outside the health field, there's a much wider body of thinking. So let's just come back to the health field and some of the work that has happened over the last little while. This is a very widely known article from The Lancet by Crook and colleagues that came out after the Ebola epidemic in West Africa, and talks about resilience as the capacity to prepare for and respond to crises, seeing resilience as something really important when there's acute shocks to health systems, and about being able to reorganize if conditions require it. But this article also talks about the fact that resilient health systems deliver everyday benefits, routine benefits, not only when there is a crisis, in other words. This is a more recent commentary, I think again from The Lancet last year, continuing the debate about what does resilience mean, and recognizing that resilience has to be seen in relation to the particular contexts in which one is working, organizing, studying. So the importance of a context specificity when thinking about resilience. There has also been quite considerable political critique of the notion of resilience in the health systems world. I want to point you to a special edition of Health Policy and Planning from last year, which reports pieces of work linked to the 2016 Vancouver Symposium on Health Systems Research. And one of those pieces of work is a commentary that is very critical of the notion of resilience. And here are some of its points, that if we start thinking about resilience in the health system, we are, in a sense, we are taking that crisis is just permanent and can never be resolved, that the notion is associated with the idea that it's the vulnerable who must themselves be resilient in order to respond to crisis, and that even if there is a bit of bounce back from crises, it isn't about tackling the pre-existing and continuing conditions of inequality and poverty. Resilience, they would argue, tells us nothing about how to address inequality and poverty. And they also argue that the notion of resilience stops us creatively imagining new futures where inequality and poverty can be effectively addressed. So they critique the notion for, on the one hand, overuse, and really, more importantly, for being an excuse for not addressing some of the critical challenges that societies and health systems face. So that's the background: a growth of interest in resilience, some ideas about what it is, a real emergence of concern for the notion after the Ebola epidemics, and critique of the use of the notion as a way of preventing a focus on inequality and poverty. So what have we in Resist been learning or considering with respect to resilience? Well, the information, or the talk that I'm giving, has now been published. The Resist website has a lot of resources on everyday resilience, as we've spoken about it. So I'm just introducing it to you, but you can go and follow this up. And there is in particular a paper from BMJ Global Health that I'm going to be using in this presentation. So we've used this notion everyday resilience, and that's picking up on the idea that resilience can have everyday benefits that Crookertel spoke about. But it's also because we've been doing work in, at least until relatively recently, systems that were chronically stressed rather than acutely stressed, if you like. Systems bearing chronic strain, and I would argue that in fact all health systems bear chronic strain. But that's the context in which we were working. There wasn't the epidemic problems of West Africa, for example, for us to address. We've also consistently tried to understand systems as complex adaptive systems, which is an important line of thinking in health systems research, and I'll come back. So we've understood everyday resilience to be about how health systems respond to chronic strain, and how they respond to it in the way they renew and reorganize themselves. And very importantly, we understand resilience to be present if they emerge from strain and challenge in some way strengthened and more resourceful. I'll come back to that point, but what we might mean by that is that in some way service delivery has been improved or scaled up, or the organizational developments that need to occur to enable service delivery have themselves been maintained and sustained over time. We also come to see everyday resilience as a product of the interactions amongst three core dimensions of any system's capacity. And here we have used the understanding that a health system, like other systems of organizations, has three core dimensions. The hardware, the things you can visibly see and sometimes touch. The tangible software, managerial processes, knowledge and skills. And extremely importantly, the intangible software, the relationships, the norms that shape interactions, the exercise of power, the presence of trust. So we've understood that those are three dimensions of health systems, and we understand that resilience is a product of the interactions amongst those dimensions. So what are the types of chronic strain we've seen in the environments that we've been examining? In terms of hardware, for example, in Kenya, in 2010, there was radical devolution of the country's administrative system that led to the creation of 40+ semi-autonomous counties, a little like South African provinces. A very radical and big bang, quick change. In terms of tangible software, in both countries, the very frequent and centrally driven multiple policy planning and management changes that have been introduced, which in this country would range from something like the Ideal Clinic to the imposition of the Public Finance Management Act over a longer period of time. In terms of intangible software, we've seen in all the environments we've worked in considerable strain in the interpersonal relationships within facilities, across levels of the system, between groups working within the system. Let me just give you a few concrete examples, particularly now of the tangible software. This is in Kenya. I pretty much imagine it's the same here. Multiple sets of reporting required in Kenya, not only around the delivery of care and different disease programs, but also around financial management. The consequences of which are that people in frontline facilities spend much or more of their time worrying about this reporting as opposed to worrying about service delivery and engaging communities. So the real pressure that that places on the front line is a strain of the system. This, and you don't even need to know the details here, except this is representing the multiple meetings that a group of 7 managers have in one district in South Africa. The multiple meetings that they are involved in that take their time, that are usually not productive, that never move the agenda on. Now, I wouldn't want to argue that meetings are not important, because they are places that bring people together to make decisions and to share knowledge. So the lesson of this is not that meetings are unimportant. The lesson is there's a heck of a lot of time spent in unproductive meetings, and that itself places pressure on these managers in terms of then how they can address challenges, how they can diagnose problems, how they can engage people in trying to move the system forward. And here's another example. This is now from Cape Town. This is a summary of primary care facility managers, what they regarded as the critical incidents that they had to address in a 4-month period. And half of them are about interpersonal conflicts in the facilities where they're working. And this is just a quote of an example of a nurse who doesn't like being told what she's going to do as she arrives at a facility, so storms out and doesn't come back for 4 days. And I don't intend to criticize that particular nurse. I don't know what the circumstances were, but the strain on interpersonal relationships in our system is a chronic strain that actively prevents the sorts of types of care provision and the sorts of forward-looking behavior that a system needs to be resilient and to move forward. So those are just some examples. Now, what happens when managers and frontline workers face this range of strain? Well, one response of managers and frontline workers is the types of chronic stress they're facing only breed more chronic stress. So where there is a significant political and policy change, let's talk about Kenya again. You know, they've established these new counties. It's come with new planning and budgeting procedures. There's been interruption in the funding processes. District hospitals, frontline facilities have had the funding flows to them sort of broken. They're not arriving. The money is not arriving. Drugs are not arriving. All of that causes uncertainty, disrupts staff and services. So the organizational changes in the broader environment generate problems that breed further chronic stress. And to give an even more catastrophic example, last year in Kenya there was not only political uncertainty, there were nationwide health strikes, which actually led to hospitals being padlocked closed. So the response to chronic stress is more chronic stress. And the challenge of instability in the environment, let's take a less radical example, the continuing discussion over whether local government services in Cape Town will be provincialized for the last 20 plus years, generates an environment of uncertainty that undermines staff motivation and doesn't provide clear direction on how staff should work together and move forward. So another response is that somebody does something. So the first response is nothing happens and you just have more chronic stress. And that second response is something does happen, but in a way that isn't generating resilience, but instead is generating what we called, using the language of complex adaptive systems, maladapted emergence. A change happens, but it's not a change that is strengthening the system. It's only a stopgap measure and may actually be in some way undermining system functioning. And this is an example from Gauteng, from before we knew about the Espaneni crisis, where a context of overspending, a moratorium on new staff appointments, and multiple new policy directives led to a situation of multiple unfunded mandates, a South African phraseology, and people got put into the wrong posts so that they could be appointed to offer services, but they're then in the wrong posts. So dietitians are in nurses' posts and more nurses can't be appointed, and vice versa. So you generate a chaotic environment in the way in which people are appointed, which does mean you get people appointed, but it fragments and confuses the service delivery environment. So there's an action, but it's not an action, there's a response to challenge, unfunded mandates. We don't have the money to employ the staff we need for this program, so we'll employ them on another program, so they are available, but then they're in the wrong program, and when that program needs to employ, you've got another problem. You generate a continuing cycle of challenge. Another type of response, which we regard as maladapted emergence, is when the nature of the response undermines what we've called the software, and in particular, the intangible software of the system. So in seeking to provide direction in newly devolved environments, in Kenya, as has been the case in South Africa, a range of new planning and management systems are introduced. And those planning and management systems seek to offer direction to all parts or subparts of the system. And there is a PFMA in this country, as there is in Kenya, Public Finance Management Act, which intends both to encourage productive use of funding and use of funding towards goals, but in both contexts has essentially been part of what's starting to drive, or what has driven, a compliance culture. And in this country, and in this province, the idea of a compliance culture, that notion, is very much a part of the language of people working in the system, that we have to just do what we are, we have to meet our targets, we have to submit the paper we're being required to. And that's from lower level to provincial level, from provincial level to higher level. That every new initiative is then seen as just something that has to be complied with, because it's not, in those colleagues' views, their experience, adding value to what they're trying to do in the system. And that compliance culture then crowds out things like local level managers really trying to diagnose problems and take action to address them, because that involves doing things that are not according to the rules, perhaps. It may mean some use of time. It may be a trade-off with where there is a need to report. And it just sort of disempowers, a compliance culture disempowers frontline innovation and creativity. And we've also seen, both in Kenya and South Africa, where the nature of those centrally driven policy and management procedure crowds out the desire, the time, the creativity of engaging with community structures and processes. So the response to uncertainty in new structures of generating or introducing new planning and management systems that are intended to have positive value for the system, the response is maladapted emergence. It's not actually encouraging the system to move towards its goals, and in fact it has negative consequences in the functionality of the system. More rarely, but occasionally, we also have seen what we would call adaptive or transformative strategic responses to the challenges and chronic stresses, chronic crises observed. Here's one example where, in the particular area of Cape Town we were working, a problem was raised that there was provincial colleagues and local government colleagues all working in the same program of past HIV/AIDS, STTB. But there were personal and organizational conflicts between those two teams of people, so they weren't working together, and they were at war with each other, if you like. They were in conflict with each other, that interpersonal strain I spoke about. Their immediate response was to say, we need a standard operating procedure of how to work together, talk together. Now, in engagement with those colleagues, they came to the understanding that a standard operating procedure wouldn't actually meet the core of the problem and wouldn't be, if you like, a living resource to draw on in the future. And they instead moved to establish a framework of principles to guide their communication with each other and to shape their relationships with each other. And they generated that guide, the managers working with the colleagues within the two programs, generated that guide together to then have available to them to frame and influence their practice of relationship as they move forward. And we see that as an adaptive and transformative strategy because it's a resource that is available to continue to influence relationships in the future. It's not an immediate response to one problem and then you put it to one side. It's also a productive resource in the sense of enabling people to come together in ways that then enable them to challenge and address problems. And in the early period after this initiative, we also saw that that process was to some extent taken up in other parts, other groups of people in the system. So it had a spread effect, if you like. We did follow up that experience. We did see sometime later that there was continuing collaboration. But these sorts of changes are incredibly difficult to maintain and sustain over time. This improvement in relationships, the continued application of the values and communication practices. They're very difficult to sustain in a system that is otherwise quite top-down, command and control driven, and facing multiple shocks. I couldn't for sure say that the set of principles that were introduced are still effectively working today. I couldn't say that, but I can say that that experience was seen sometime after the creation of the principles as a really valuable experience that within the system people can learn from about how to bring people together to work constructively towards common goals. Now that's a quite different type of response to a standard operating procedure or to the types of maladapted emergence that I spoke about before. So with that sort of quite sketchy overview of a really rich set of experiences over quite a long period of time, let me be clear that in Kenya we've been working since I would say about 2012, 2013, in Sedibeng, a similar period of time in Cape Town since about 2011. We've been working in the same geographic areas with the same groups of people, barring those who've moved out of the system. So there's quite a rich set of experiences in all three locations. With that set of experiences, we go on to argue in this paper that in thinking about everyday resilience, it is this intangible software that is critical. Things like the values and the norms that shape professional practice and interpersonal relationships. So in one of the Kenyan experiences, managers went the extra mile because they felt committed to their staff, notwithstanding the broader environment of change and broader environment of change and chaos, really. And in South African work, we've seen from very careful studies that altruism is incredibly important to health workers' decisions of where they're going to work and whether they're going to stay and remain in rural areas. And that's another part of the RESIST body of work, the importance of altruism in driving health worker decision-making about where they're going to work. We also want to argue that the relationships and the networks among people and groups and the routines that underpin those relationships are really important to organizational capacity to deal with challenges. And in the past example, the bringing together of people to work together, as opposed to just imposing a standard operating procedure, that's an example of relationships important to responses to challenge that enable positive responses and that are a resource for the system to continue to work with. And the third point is that we've really seen that the middle manager leadership is critical. And by middle managers, I really mean everybody from a primary care facility manager to substructure or sub-district managers in the South African context, that group in particular, and then you can go up to the district level, that they're the ones who mediate these things that come from the top, ideal clinic, as an example. They're the ones who have to then engage their colleagues in implementing that. And they have to try and translate that experience in ways that the colleagues then say, okay, we're going to do this, rather than just, oh, we've got to do it. They're actively going to get involved in it to make it happen in productive and constructive ways. And they have a really important role in the way they communicate and in their role modeling of communication practices and in their acknowledgement and reinforcement of the importance of positive relationships within the system. And from those sorts of ideas, we want to argue, or we have argued, that the notion of everyday resilience, this thing in the system that is enabling a system to respond to stress and move beyond that, requires new forms of leadership, not leadership that is located centrally only, but leadership that is spread across the system, where the cleaner can offer leadership within the system, leadership that is based on respect and support for others. And we argue from some of what we've seen that enables creative problem solving, and that's what's also very important, the ability to respond to problems in creative ways. We also argue that this is not about individuals. We cannot just say this is a responsibility of individuals, the good manager, the good health worker. We have to think about the system as a whole, about organizations as a whole, and therefore that organizational fabric, the tangible and intangible software of the organization, has to spread agency and leadership within the system. So the routines of organizational life have to empower people, have to encourage constructive relationships, rather than, for example, a compliance culture. In our work, and I'm not going to go into that too much here, we've also begun to think a little bit about what the notion of everyday resilience, the way that we have conducted our research, might suggest about the roles of researchers in helping to nurture everyday resilience. So many people would say, yeah, but what about the resourcing? You can't do anything if you don't have money. And of course that's true, or people. And of course that's true. What we would argue is that an adequate platform of resources is absolutely necessary, but it's not enough by itself to enable that resilience, that response to challenge that moves the system forward. And in fact, we would also argue that some of the, that when one's thinking about resourcing, it's incredibly important to acknowledge that the way new money comes and is channeled may itself generate maladaptive emergence. The ways in which funding is directed towards facilities, additional funding, if there is such a thing, may itself, oh, that means I've done my half an hour, I'm nearly done, stop. That may itself generate maladaptive emergence. Pay for performance is a widely recommended strategy for channeling money and encouraging behavioural responses from health workers. Pay for performance may generate some positive outcomes, but it can also undermine altruistic motivations, for example. All of that is on a graphic and a small animation on the Resist website. So again, you're welcome to go and have a look at that. I just want to end with some thoughts about what the contribution of this still emerging body of work on everyday resilience is to those broader discussions I referred to. Our first point is that despite that wealth of Google hits in every sphere, the vast majority of work is actually conceptual, theoretical. And a recent just published review of empirical work inside and outside the health sector only found 34 papers it could draw on. Resist has conducted empirically led and what we would call theoretically informed research. So we are seeking to understand the system as it works, as well as think about how theory can help us understand the system. Against the backdrops of the current debates, we've argued that it's important to think about resilience as not just the response to crisis or to shock, but as something that is an everyday phenomena in health systems. That it's about more than bouncing back. It's not just about bouncing back to where you were, it's about moving beyond where you were. That the resilient response can actually add value to a system and enable you to do things in different ways that are more useful to society, if you like. That resilience requires us to think about hardware and software. It requires creative learning and adaptation, and not just a resort to the response of the normal way we address problems, like a standard operating procedure. It requires creative thinking of how to address problems. And we just have to embrace uncertainty in an uncertain world where we want to encourage resilience. We have to work with uncertainty, and resilient responses have to both understand uncertainty, deal with uncertainty, and still move forward. We would argue that it is not necessary in thinking about resilience to assume that you're just going to bounce back to inequality and poverty. We would argue that resilience offers the opportunity to identify new ways of being and doing to allow us to begin to think about how to tackle inequality and poverty. What does it add to health system strengthening? We would see resilience as an additional characteristic of a strong health system, beyond resourcing and some of the usual things, but a characteristic that can't just be locked onto a system, that has to be nurtured and has to be drawn together through a process of health system strengthening that is evolving and dynamic and works with uncertainty rather than trying to rule it out. And that acknowledges that in every system, multiple changes are happening at the same time. So resilience a resilient response needs to work through those multiple changes. There needs to be synergy in the types of interventions that are being introduced into a system rather than conflict, if you like. And I want, as a final slide, and very much hoping we can then have some discussion, just to draw out a few points that we have drawn as lessons for donors, that's one of our audiences, as lessons for national governments in particular. Here's a few points that we've drawn out. That when there's a time of crisis, call it drought, do no harm. So in the way you respond to crisis, it is important that one doesn't make things worse, that one watches out for maladapted emergence in particular. Secondly, that it is important to adopt supportive and enabling roles, donors with respect to national stakeholders with respect to local stakeholders. Don't revert to the top-down mentality that really colours all sorts of action within the health arena and within government arenas and within global reasons. Don't usurp the local level leadership, however you define local, that is necessary to respond in resilient ways to challenges being faced at a local level. Invest in health system software. What does that mean? Well, it certainly means people, but it's not just more bodies on the street. It's also encouraging those bodies to think about how they work and to work with each other in ways that enable a collective response, in ways that build the transforming norms of the system, norms that become a resource for future action, trust-based relationships, for example. And the last point here was that as interventions happen, or as organizations think about interventions, they need to think about their own organizational practices, because the way they do their own business affects the way they then engage others. And if we're thinking about donors, and this comes out of a series of discussions we've had with donors, there's often a gap between those who work in the humanitarian assistance field and those who work in the development field. And they don't even talk to each other. So when they're in countries seeking to offer support to countries, you actually can have parallel programs of work going on. So they're not being synergistic in the way they work, and that has consequences for the way they engage with systems. And I would think that the same is true in government, that where you have silo working at the top, you're going to have silo working at the bottom. So if you want to encourage cross-silo working, you regard that as important, you also have to think about your own organizational practices to encourage that. As a last point, I think we might even review these points for our university's response to a range of challenges that it's facing and see what messages they might have for us and for the array of leadership in this organization. Thank you. So that was quite an array of information and ideas, and I recognize that. But I hope it prompted some thoughts, some comments, and I do think that resilience is something relevant to us now, as well as to the system around us, and to other countries and systems as well. So, questions, comments, further reflections?
So it occurs to me that that how an organization responds to crisis is very dependent on how they respond in an everyday with everyday resilience to day-to-day stressors. And in workplaces where I've been personally or I've been aware of, if the culture can't really adapt to the need, if leadership changes or staff, you may have the best culture for responding, and then things shift and change, and the systemic or systematic resilience doesn't really maintain itself because you have to have some key players. And have you thought about how does that carry on? I mean, I just see things fall apart when certain champions and people leave a system that might have been working well, and with the intangible software that you're talking about, now it's not.
Sure. So, I mean, I think that there isn't a static moment in a system. It's a continually unfolding ball of energy, really. And that, therefore, one just has to acknowledge that there is a process of unfolding over time. And, there may well be, over time, processes of less resilience, more resilience, less resilience. And I'm not sure that we can think about, we've got this much resilience, now we can hold on to it and build it. So then I think we have to think rather about, how do we continue to try and encourage resilience? And that is partly about individuals, but maybe it's also about establishing these routines that work differently. So if we made meetings more productive and we had fewer of them, maybe the meeting and its agenda would remain even as the people in it move on, and there would become a new way of being in meetings that itself is a resource for resilience. And maybe we have to think more at the micro level of individual routines or particular practices rather than at can we maintain it across the system as a whole. But I acknowledge the point, and I think we need to keep thinking about it. Other points, comments? Gosh, there's a lot of people in the room. You can't all be quiet. Yeah, well, thank you.
So I don't know a whole lot about resilience, but thanks for a fantastic talk. I want to give an unashamed plug for a related noon meeting, which is going to be on the 19th of April, where I've invited the person to be the head of the pediatric ICU at Red Cross and is now the head of pediatrics to come and talk about work that he's been doing with a group of people involved in those kinds of activities, which are called, and they're a group called Risky Business. And that's an environment where resilience is critical. The pediatric ICU kind of can't go wrong. And I thought, as you talked about these microsystems that need to be resilient, that might be something that would be of interest to people.
Great, and a good example of networking productively in ways that generate new resources for all. Yeah.
Another question is, how do we instill that set of values and practices and, for want of a better word, leadership attributes in our students?
In the students?
In our students. Because that's one of the most powerful ways in which we as a university can be contributing to a shift in culture. And very often the medical curriculum is filled with knowledge, skills, until people's heads are bursting. But where is the relational content? Where is the opportunity to innovate, to take initiative, and to learn collaboratively from that
Sure.
experience?
A really good question. Does anybody have thoughts on that question? I mean, my immediate thought going in my head as you were talking is that we do have very different groups of students in this university. So, obviously there's the important body of medical students, but we also have postgraduate students from various disciplines and perspectives. In our division, we are running a health leadership program where we're specifically trying to work with managers in developing their emotional intelligence and their ability to work within systems. But within a crowded medical undergraduate curriculum, where would it come? How would it come? I think that is one of the questions the university has to face. And I don't have an answer. Yeah, Leon.
This is what to, I think, an easy answer to that is the encouragement of interdisciplinarity across teams in the medical track, specifically that being a part of very class. But yeah, nurturing those kinds of respect for others, embracing uncertainty and the need to work with others in order to solve complex problems. So those are kind of easy ways to
also allowing space for creativity and mistakes. Because students are leaders already. We've seen them lead. So, and they're leading into our future.
Jill?
Would you have a way the theory on everyday resilience connected to the broader theory on kind of resilience to crisis kind of resilience? And I suppose I'd be wondering whether, I mean, if a system has a particular level of everyday resilience, does that mean it would also respond in a resilient way to a shock rather than a stressor? I mean, so, you know, or would something totally different type of resilience be required to respond to a shock than it would to respond to a stressor? So, I mean, just me, I'll be thinking like, so if a system has good everyday resilience, which means they have these software and they have these ways of being that respond to chronic stresses, that might mean that they actually are not well situated to respond to a crisis, which requires a kind of a top-down, strong arm kind of approach. I don't know.
Yeah, and so let me be clear about a couple of things. I mean, we've worked with the notion of everyday resilience to try and stress that we see in the systems that we've been working with a need for everyday resilience, given the range of stress and shock that is going on all the time. The question of is it a different energy, if you like, to that which you need to respond to an acute and chronic shock was a conversation in a workshop that we had last year, where we brought together colleagues from Liberia, Sierra Leone, Kenya, you know, a whole range of different places to discuss their different experiences. And the conclusion we came to, which this poor diagram is trying to explain, is that there is in every system a range of rain clouds, chronic stress, and lightning, acute shock. And that that there are also multiple responses going on, some of which only bring more problems, and some of which are trying to address those problems. So that I think we discussed in that conversation that every system, even those that are addressing acute crises, do need everyday resilience, because in those acute crises there are chronic stresses going on. And in systems that are primarily dealing with chronic stress, there may be an acute shock coming. So it's a property of the system that needs to be developed as part of system strengthening. Now, I don't think it would be fair to say that we would necessarily see resilience as only about intangible software. It's about the interaction between that and other dimensions of a system. And in fact, to have more effective hardware interventions, you may also need the intangible software. So I think that's a point that we need to talk about more. But I think we were coming to the conclusion that every system needs some everyday resilience, and it's a resource for the system in responding to acute shocks. But maybe there is something else that needs to happen at those times. Please. Gentleman at the back, and then forward.
Oh, I wanted to know if you talking mostly about developing countries, and in your experience or your opinion, are our systems in richer countries more prone to stress or shock than in poorer countries?
So our work has only been in South Africa and Kenya that has underlined this work, although we have colleagues in other southern settings. So your question is are higher income countries more prone to shock or stress? I'm not sure that I can answer that from an evidence base, but my gut feeling is somewhere like the NHS in the UK has been responding to shock and stress and chronic crisis endlessly. The constant reorganisation of the NHS is a problem. And in the UK, in the US, you've got a broken system. But I'm not sure that that's more broken than our systems or less broken. I don't know how we make that call. Yeah.
So you spoke about a broken system, and I can't help to think of provinces such as Mpumalanga and Eastern Cape and Limpopo. So where would you begin? We understand resilience now. We go back home. Where do we begin?
Sure. So, and clearly we've worked in Gauteng and the Western Cape and not in Eastern Cape and so on, but of course we do have other experience and colleagues working in those settings. So I strongly believe that everywhere in this country are pockets of positive performance and resilience. And the challenge, I think, is how to string those pockets together so that they are system-wide. And I think one of the big problems of the country is the weaknesses in the provincial layer in many settings. And for me, I wouldn't argue get rid of the provincial layer. I don't know how you can rule from national level to the bottom, as it were. But I think that we do have a problem of the provincial level, and we haven't yet really been able to come up with resolutions of how to strengthen the provincial level as a player in the system. And that clearly is what this province has done more effectively than other provinces. But I think, I don't know if any of you heard Erin Motsoledi last week talking at the Life is a Demeni hearings, and any of those Life is a Demeni. I mean, we have a broken system internally. It's not just the provincial though. It's the practices within it. And you can't just command practices to improve. You can't say, if you're the Minister of Health, everybody do better. It has to be built internally from pockets, spreading. I just don't see any other way of doing it.
I was wondering, just a point of clarification. If you think about middle management, who is it like clinic managers? Is that your middle management level?
So I think they are one of the groups of middle managers, but there are also sub-district managers. There are managers in the programs who work more at a sub-district or district level. So it's that sort of group.
Okay. So but it's all together.
Yes, I'm not distinguishing, this group only. I mean, people are in the middle of the directors from the top. I mean, if you're at provincial level, you're in the middle relative to national. So it depends a bit what perspective you take.
Okay, thank you.
Okay. Nance, was that your hand earlier?
Yeah. I just have a question about compliance culture, in particular to the ways in which health workers use that as a form of resilience. It is resilient. It is a form of everyday resilience, I would interpret, to be able to cope with the demands of the stress and the strains of the system by being compliant, by finding strategies to make it easier to work within the system, within a very difficult system. And so how do we, what do you suggest the processes are to facilitate the recognition of individual agency to not be complicit in that compliance?
So, I don't have the answers to all these questions, so please do chip in, everybody. But I suppose one of the things that we feel from what we've seen is that resilience, that we need to think about resilience not at a personal level, but at an organizational level or at a system level. And so when individuals cope with the challenges of the work of their settings, that coping is an important mechanism for them and their ability to keep going to work. But it's not an organizational resource. It's not about organizational resilience, and that coping may actually be a maladapted emergence form of resilience for the organization. So then the question becomes, what is it in the and culture is not an individual, it's that which is around us, influencing multiple individuals. So how does one turn a culture around so that it is less disempowering, less risk-averse, and is more encouraging of risk-taking in a small sense and creative problem-solving, if you like. And there, the point that I've made so far is that we have to encourage different forms of leadership, and that is not leaders, it's an understanding that leadership is an energy in the system, and it's encouraging that energy to be built and developed by individuals, but by individuals working in teams, and so then the way the team works is important. And also that has to be nurtured, if you like, from the bottom up, from the periphery, rather than exclusively from the centre. The centre has to, any centre level has to say, we want a bottom-up process, because if they don't want it, there's a problem as well. And they have to create an environment that nurtures and encourages it. But it's a bit back to the issue of, how do you create pockets and how do those pockets spread? And if we can think of resilience as an energy in the system, then what we need to ask is how do we get that energy flow going? And there may be multiple answers, not just the ones I'm giving. But it's not a building that you stick into the system, and it's not a new organizational structure. But what do others think? Arnie?
Thank you. It sounds very nice and ideological, but one of the elephants in the room is this. The fact that the healthcare system is one of the most hierarchical that I know of. And I wonder what your take is on inequality, systems that perpetuate inequality under the guise of merit or competition. I mean, it sounds, and also just the subliminal messaging. I'd hate to be part of a bottom-up process. What does that sound like? What does it say? And when you mentioned about the cleaners are also leaders, the underlying subliminal messaging is that despite you being so far down the bottom and being so unimportant, we're going to expect you to do something, but by the way, don't expect to be taken seriously given the hierarchy and the way that we see ourselves in the system.
Sure. So, I mean, we saw very few signs in the work that we've done of the more transformative end of resilience. We saw more signs of chronic stress, breeding chronic stress, if you like. So that we exist within a very hierarchical system, I'm not denying at all. That hierarchical system is a source of chronic stress, making life difficult, is partly is important to recognise. If we want to change, then we have to think about how to change. And maybe in what you've just said, there is an element of, we have to change from within as well as seek to change the system around us. So of course there's always going to be an element of individual response and individual thinking differently. Thinking differently is the first step to acting differently. So we do need that. But if it's only the individuals who change and the system doesn't, then we're back to square one, if you like. So whilst, in many ways we've seen positive experiences, we have also seen some green shoots. So our question is, how do you nurture those green shoots? Not, oh, well, they're going to die anyway. I can't work like that. I can't, it's not, we have, as individuals, I think, have to have hope and the opportunity of change in order to move forward. And that is itself an energy and a resource for the system. What I'm trying to say is we need individuals with hope, trust, energy in the system, but those individuals need to become a collective to change the system. So how do we think about that collective? And, it's very difficult to both think about this, to talk about this in environments that are hierarchical and that value particular forms of knowledge, particular forms of acting. That's true of the university as it is of the health system. So it is very difficult. But there are, I think, for myself, I would argue that the notion of resilience gives me some ways of thinking and ways of talking about acting, and maybe, hopefully, ways of acting myself that I can try. And I've always believed that, you start with yourself and you try to spread, and that's something that we have to build on. But I don't deny everything you're saying, Annie, and I don't deny the difficulty of things.
If I can just make a follow-up comment, maybe that was just my interpretation, but I've heard a lot of senior management talking about resilience, and the underlying narrative is that all of you down there need to come up with something, but there isn't an explicit acknowledgement of we actually need to change the system and do away with these barriers that are actually inhibiting your agency, your leadership, your ability to make a system resilient.
Yeah, I mean, one of the other things that we found in the work we've done is how many different perspectives there always are on the same experience. And so, everybody sees things slightly differently. And that is not to deny the validity of one's own perspective. But it is important to acknowledge that within the system there are multiple perspectives. And one of the issues, I think, is how one brings people together in ways that allow the sharing of those perspectives. And I can only say from the engagement that I've had with colleagues thinking about resilience that I don't think they see it quite like that. But that's my experience, not yours. Anything else?
Yeah. I just have one question regarding, maybe it links a little bit into what you were saying, is you talk about diffuse leadership, but when I hear you talk about leadership, it sounds a lot like responsibility. What's the difference between your definition of leadership and just assuming responsibility for ongoing action?
Now here's one of the challenges in this area of work is that we end up thinking conceptually, perfectly acceptably, and it becomes, how did you understand that? What's your understanding of that? And that becomes one of the difficulties of actually generating collective action. I suppose I'm understanding leadership as a practice and a behaviour and an engagement with others. And I don't see that as the same as responsibility, but maybe you do. Let's come back to meetings. So meetings, everybody said, oh yeah, meetings, there's many of them, they take too much time. We all think that. But meetings are the place where we get together and have the opportunity potentially to engage with each other. And if we don't do that engagement, we won't even develop a common language about what we're talking about, but it's how we use those meetings as well as, not only being in meetings. Just throw that into the wind. And I see it's 1 minute to 1. So anybody like to have the final word? Yes, please.
Just a way of comment from my side, not a question.
Sure.
But I'm wondering whether the issue of emergence and the embracing of emergence in terms of health system strengthening is the emergence of health system strengthening through resilience is not actually a phenomenon, an emergent phenomenon in complex adaptive systems in a specific time and place. So in other words, as we were talking at the beginning of the talk as to how if you have a complex adaptive system, you actually have emergent behavior that could not be foreseen because of the interaction between all the actors. So coming from that angle, you could actually say that this is an emergent phenomenon.
Yeah.
And the reasons for that, I think, was starting to intrigue me. Why resilience now? Why focus on resilience now? Because I keep asking myself the question on, if it is a system that tries to be resilient to its function, and it doesn't matter in all my time as working in health system, in the public health system, I haven't heard of a hospital that's lost its function.
Yeah.
It still remains a hospital.
Sure. So why are we thinking about resilience now?
Yes.
What does it add? Will it go away when a new jargon comes along? This may be true. And health systems are emergent and ever developing. Thank you very much, everybody. And don't forget the next session on resilience or something like it in April. Great. Thank you.
save you the trouble.
Okay, thanks so much, Jim.
Exactly one of those things that
Very nice to meet you. Why are you Yes, very likely. Yes, very likely.